How are MPNs treated? This question will be answered by Dr. Gerds.
All right. Thanks, Jackie, for kind of setting this up. And moving forward, we'll kind of take the same pattern. We'll go over each of the diseases to kind of look at what things are considered when a patient, after a patient's diagnosed, and how we might treat them. With polycythemia vera, again, there are too many red cells, or the hemoglobin or hematocrit is too high. And really, across both both polycythemia vera and essential thrombocythemia, a number of surveys have been done asking patients, what is your biggest concern over time with your disease? And patients, more often than not, say, well, I'm most concerned about disease progression. Progression to either myelofibrosis or to acute leukemia. And certainly those can be devastating consequences of the disease. And so certainly we want to do things to minimize the risk of progression. Certain medications that were used commonly in the past aren't used anymore because they do increase the risk of progression. But those are kind of rarer events for both polycythemia vera and essential thrombocythemia. And the thing, when you survey doctors, what are they most concerned about with a patient with PV or ET? And they say blood clots. And so certainly there is some of a disconnect there between docs and patients, and we certainly, with things like the NCCN guidelines, are trying to narrow that gap. But blood clots are on the top of the list because they are more common. And so we do things to try to reduce the risk of blood clots. In patients with polycythemia vera, two things have really been shown to dramatically reduce the risk of blood clots in patients. One is simply a baby aspirin every day. There was a trial where half the patients in the study who had PV got aspirin, the other half didn't. And in fact, the aspirin did a remarkable job at reducing the risk of blood clots, nearly a reduction in half of the relative risk for those patients who took an aspirin versus those who did not. Phlebotomy is often used to lower the hematocrit, and so is hydroxyurea or ruxolitinib. And we know from another study that keeping the hematocrit under 45% can also dramatically reduce the risk of blood clots and other complications in polycythemia vera. So whether by phlebotomy or hydroxyurea or ruxolitinib, we want to keep the hematocrit under 45% in patients with polycythemia vera. When we think about should we add in a medication in addition to phlebotomy, we basically think about two groups of patients. Anybody who is under the age of 60 and has never had a blood clot before is considered low risk, and everybody else is considered high risk. Low risk patients, we focus on using phlebotomy and aspirin, as well as modifying other risk factors for blood clots, such as diabetes and cholesterol and smoking and those types of things. In patients who are high risk, we often consider adding in something like hydroxyurea in order to help control the blood counts a little bit more tightly. For essential thrombocythemia, we do a very similar thing where we try to identify patients who are at higher risk for blood clots in which we might want to use a more aggressive treatment in order to lower the platelet counts. And in addition to age and whether or not a patient has had a blood clot before, we also add in whether or not they have the JAK2 V617F mutation as the driver mutation for their ET. We know that patients with this JAK2 mutation are at higher risk for blood clots than those with calreticulin or MPL mutations. And so this is something called the revised IPSET score, where we can calculate based on risk factors what an individual patient's risk of thrombosis might be over the course of a year. So patients who are under the age of 60, who've never had a blood clot, and do not have the JAK2 mutation as their driver mutation are in the very low risk group. And their risk for blood clot is somewhere around 0.4 to 0.6% per year. And if we look at the high risk group, those are patients over the age of 60 who have had a blood clot in the past and have the JAK2 mutation. They are on the other end of the spectrum, where for those patients, the risk of a blood clot is anywhere from 2.5 to 4% per year. And that can help to decide what patients should we start trying to lower their platelet counts and get tighter control of the disease, and which patients we shouldn't. So on the left-hand side of this figure are the low-risk patients. And in addition to careful observation and considering aspirin for all these folks, we would be less likely to give the very low or low-risk patients a medication to lower their platelet counts unless they were exorbitantly high. Because we know that adding a medication in to lower their platelet counts doesn't necessarily make them live longer or live better. On the right-hand side of this is the other extreme, patients we know that are high risk for having blood clots. And so in addition to aspirin, we often use a medication to lower their platelet counts. In the middle is a little bit tougher. There's not a lot of clear evidence one way or the other. Should we use a medication to lower their platelet counts or not? And that's where we kind of take things on an individual case-by-case basis. What other risk factors for clots the patient might have? What are the patient's preferences and other factors that might influence that decision? And again, that's a really important time to sit down with your doctor or MPN specialist and really kind of hammer out an individual plan for you. For myelofibrosis, one of the ways to think about disease are what symptoms does a patient have, and trying to address trying to apply a specific treatment for the symptoms. For example, a patient with anemia may feel run down and tired, and you would want to use an intervention in order to improve their anemia, whether simple transfusions or medications such as erythropoietin or danazol. Other patients with very aggressive, high-risk myelofibrosis, you and your doctor might be considering more aggressive treatments such as ruxolitinib or even transplantation, because we know that patients with very high-risk myelofibrosis are likely to transition to acute leukemia in a short period of time. But we do have a risk stratification system as well for myelofibrosis in order to help us frame these conversations about what treatments to do. And this risk stratification system helps us identify patients who are at low risk and those who are high risk, those with very slow-moving disease or potentially very aggressive disease. And at the top half of this chart, there is the risk factors are listed that we consider. Age, whether or not a patient has constitutional symptoms, that's night sweats, fevers, or weight loss, whether or not a patient has anemia, a high white count, or circulating blasts. Those are very, very immature white blood cells that we see in the bloodstream. Normally, individuals do not have very many or any at all that we can count, but sometimes patients with myelofibrosis, when their bone marrow becomes very, very sick, we can start to see these come up. So we can add up the points here depending on what risk factors are present, and patients can be stratified out into low, intermediate 1, intermediate 2, and high risk disease. And it goes along with different pace of disease. The patients who have 0 risk factors in the low risk group, their average survival in this initial study was so long that we weren't able to calculate it. That's why it says NR there for median survival in the low risk group. On the other end of the spectrum, patients who have high-risk disease, where they have a large number of the very aggressive risk factors here, on average, we predict that those patients would live about 1.5 years. So we know that the tempo of their disease is very high, and the more aggressive the disease, the more aggressive we want to be with our treatments in order to properly address what's going on. And this is just another way of looking at it, and this is often what your doctor is thinking in their mind when they see a patient with myelofibrosis. What are their symptoms? What is their disease risk? And that helps us try to parse out what particular treatment to pick. So this maze of spaghetti here with all these little boxes is kind of what's going on in your doctor's mind when he's sitting down with you and trying to figure out what treatment should we do to best address what's going on with your disease. Certainly one of the big things that have happened in the field of myeloproliferative neoplasms in general is the discovery of the JAK mutation. So JAK is a gene that is often mutated in these diseases. And in fact, it turns out that the calreticulin mutations and the MPL mutations, they all kind of do the same thing. They lead to this JAK signal being on all the time. The analogy I use in clinic is that of a thermostat and a furnace. When your thermostat senses that your house is cold, it tells the furnace to kick on and make some more heat. And then when there's enough heat in the house, the thermostat then says, okay, we have enough heat, you can turn off furnace. And there's that kind of cycle that goes, and sensing what's going on in the environment and addressing it as needed. What happens when a JAK mutation, and your body has those same systems where it says, okay, we have enough blood, we don't need to make more, or wait, we're getting a little low on blood, we should make some more. And that same thermostat system exists in our body. When a JAK mutation happens inside of a bone marrow cell, the signal is on all the time. It's like no matter what the thermostat says, the furnace is always burning. Those cells are always making new blood cells. And that cycle just goes and goes and goes. And the drug ruxolitinib actually dampens that signal. It turns down the furnace, if you will. And by turning down the furnace, we can lower blood counts. And also, it also lowers this stuff called cytokines. Those are substances that are released by the immune system that often lead to many of the symptoms that are present in MPNs. And that's how ruxolitinib has been able to help so many patients with MPNs. But whenever we're thinking about an individual patient, we not only think about how well a medication works and how aggressive their disease might be, but for that individual treatment, we also want to balance side effects with efficacy, because side effects can be just as important as how well a drug works to treat the disease. So this is from a cartoon, a syndicated cartoon called the Pajama Diaries, and the author does have essential thrombocythemia, and she's often written about what it's like to be a patient with ET and the side effects that may go along and making tough treatment decisions. So if you're interested in reading more, she does post a cartoon every week. Not all of them are about MPNs, but some of them are. And you can, I found these are listed on cleveland.com in their cartoon section. That's where I got these from. But it's kind of interesting, and she puts things in, I think, in good perspective.